Hello, everyone. Welcome to our webinar today. We'll get started in a few minutes. We're just going to give everyone a couple minutes to gather. But thank you all for joining us today. Already got a good number of people here. That's great. Hello and welcome to all of you just joining us. We're just going to give it another minute to let people gather, but thank you for joining us for our webinar today. We'll get started pretty soon here. All right, so we're going to go ahead and get started. So hello, and thank you for joining us for today's National Conference of State Legislatures webinar, State Policies on Midwives and Doulas. My name is Emily Blanford, and I'm a program principal in NCSL's health program, and I'll be moderating our webinar today. Today's webinar is co-hosted by the Association of Maternal and Child Health Programs, and we'd also like to thank the Health Resources and Services Administration's Maternal and Child Health Bureau for their support. So for those of you who are joining us for the first time, NCSL is the bipartisan membership organization serving state legislators and legislative staff in all 50 states and all of the territories. Our goals are to improve the quality and effectiveness of state legislatures, promote policy innovation and communication among state legislatures, and ensure a strong voice for states at the federal level. We do not take positions on state policy, but we do provide research, education, technical assistance, and opportunities for cross-state sharing. So now before we get started, I just have a couple housekeeping items for us. So today's webinar platform is a platform for information exchange and engagement. So over the next 60 minutes, we encourage participation through our chat and our Q&A boxes. So the Q&A box allows for upvoting, so please ask questions for today's speakers using that Q&A option. And you can use the chat box for general questions regarding today's webinars or to connect with other attendees. So to familiarize yourself with the chat function and also learn who's on the line today, please feel free to type in the state and your title and where you're calling from today. And also, we will hold a formal Q&A during the last part of the webinar after the presentations, but we will take some questions for Delegate Aird immediately following her remarks as she has to leave early. And lastly, today's webinar is being recorded and will be available on NCSL's website along with a PDF of the slides within the week. So now that housekeeping's out of the way, let's get back to why we're here today. So the US has the highest rate of maternal mortality among similarly wealthy nations, and there are significant disparities in maternal health outcomes. For example, Black and Indigenous mothers die at 2 to 4 times the rate of white mothers and rural women face significant barriers in actually accessing obstetric care. Some states have increased access to midwives or doulas as one part of their statewide strategy to address maternal and infant deaths, and also decrease related disparities by race, income, and geography. Now, midwives and doulas are one component of the overall system, and NCSL has received an increasing number of questions from our members related to this topic in recent months. So recognizing that this one aspect may be a new topic for many of our members, we are offering today's webinar to provide background information and legislative examples on this one particular component of the overall system. So joining us today, we have Jessica Steiger, Hein Wen, Delegate Legislators Aird, and Representative Stephanie Hilferty. For full speaker bios, please see the attached document that will be dropped into the chat box. Now, these experts, they will discuss the roles midwives and doulas play in maternity care in the United States and relevant state policies that our team at NCSL has been tracking. 2 legislators will also share their state's actions on midwives and doulas, including lessons learned in those respective states. So first up, we have Jessica Steiger, Program Manager of Infant Health at the Association of Maternal and Child Health Programs, or AMCHIP. Jessica is also a certified lactation consultant and a certified doula. She'll provide a brief overview of midwives and doulas and the roles these different professionals play in the U.S. So thank you for joining us today, Ms. Steiger. I'll turn it over to you.
Awesome. All right, I'm gonna turn my camera back on. Can you hear me?
Yep.
Beautiful. All right. Well, it's great to be here, folks. My name is Jessica, and I'm going to be talking a little bit today about midwives and doulas. And just wanted to tell you quickly a little bit about who I am. I know you have my bio, but I wanted to share, as Emily mentioned, I've been a birth doula myself for about 7 years, and then I went to the University of North Carolina at Chapel Hill, where I received my master's in public health and my master's in social work, and I concentrated in maternal and child health. So I focused a lot on maternal health systems and really especially the opportunities for the midwifery model of care and doula support in the United States. So this is very much up my alley. And now I work at AMCHIP, where I manage our portfolio related to improving perinatal and infant health. So I have just some objectives for our brief time together today. We're going to talk about the different types of midwives and the difference between midwives and doulas, talk a little bit about how midwives and doulas engage with other maternity care providers in the United States to address maternal health, and then talk a little bit about the role that midwives and doulas play in maternity care across the country. So just quickly, I'm mindful that folks might not be familiar with AMCHIP, with the Association of Maternal and Child Health Programs. So we're a national resource partner and advocate for state public health leaders and others who are working to improve the health of women, children, youth, families, and children and youth with special health care needs. So essentially, AMCHIP develops resources for maternal and child health practice. We provide technical assistance to public health leaders, and we support peer learning opportunities in a nutshell. So let's dive into talking about midwives. So I have here a definition for midwives. There are a lot of ways that you can define a midwife, but I'm going with this. Midwives are trained medical professionals who are experts in normal pregnancy, labor, and postpartum, as well as other aspects of reproductive health, and they provide skilled support for low-risk pregnancies and births. So there are a few different types of midwives. In the United States, there are really 3 categories of midwives. First would be certified nurse midwives, and these midwives are trained as nurses, and then they go on to receive a master's level education in midwifery. These midwives practice primarily in hospital settings, but they do attend, some of them do attend births in out-of-hospital settings, like in homes or birth centers. The second category of midwives are kind of generally known as direct entry midwives. And there are sort of 2 subcategories there, but direct entry midwives complete a training program, typically at an accredited institution, and then supplement that academic education with an apprenticeship. I think the biggest difference here is that direct entry midwives don't necessarily come to midwifery with a healthcare background in the way that nurse midwives do, but some of them do, as you can see in the kind of breakdown between a certified midwife and a certified professional midwife. So these midwives, while they don't necessarily have a healthcare background, they do receive really comprehensive education in pregnancy and reproductive health. And the reality is that sort of some states have certified midwives, some states have certified professional midwives, some have both. It really just depends on the licensing and practice laws in your state, whether you'll have what kind of direct entry midwives you'll have. And then the last category is traditional midwives, who may have completed their training in one of a variety of different ways, but choose not to pursue licensure, and so they choose to sort of remain outside of the typical medical system. So I also want to just touch on the midwifery model of care. So I've got a kind of description here of the midwifery model of care. It's really focused on the idea that pregnancy and childbirth are normal functions of human bodies, that there isn't anything inherently wrong with birthing people. Midwifery visits tend to be longer. They focus on education to prevent complications. And so that education might include a focus on prenatal nutrition, stress reduction, safe physical activity. And the midwives can also help to connect folks to supportive services and resources that they might benefit from. Midwives who do deliver services, especially in a home setting, have this added advantage of seeing where patients live, and they might be able to make more in-depth assessments of a patient's needs as a result. And then I want to also mention kind of the impacts of midwives on maternal health. So here I've put some information about outcomes associated with midwifery care. And it's true that much of midwifery care is delivered in a medical setting like a hospital now. But I also wanted to show some evidence that midwifery support out of hospital birth settings can also be a safe option. And I like to emphasize that because sometimes we hear really scary stories. So I just like to present some information here that can be a safe option for some people. It's important to recognize that these positive outcomes are really associated with low-risk pregnancies. So midwifery care is really designed to work in conjunction with the medical model. So when someone is experiencing a high-risk pregnancy, so let's say, for example, they have a pre-existing health condition like type 1 diabetes, or maybe they develop something like preeclampsia in the course of their pregnancy, the midwife would then either work in partnership with a specialist like an OBGYN, or they might potentially transfer the patient's care entirely over to an OBGYN. So there are medical conditions that can be managed by a midwife in a hospital setting, but maybe are deemed unsafe for management in an out-of-hospital setting. So an out-of-hospital midwife would refer a patient with one of those conditions to a provider in a hospital. So I like to kind of talk about that because part of why the outcomes are so good has to do with midwives' expertise in normal physiologic birth, and because they have the ability to partner with and refer patients to OBGYNs if the patient is no longer experiencing a low-risk pregnancy. So in a well-functioning medical maternal health care system, we would have midwives and obstetricians working in partnership and having midwives able to fully access the medical system when they need to. And that's an important part of keeping maternal health safe. So if a midwife determines that they need to transfer care of a patient into a hospital setting due to a high-risk circumstance, the hospital healthcare system really needs to have like a system in place for supporting that safe transfer of care. And I mention that because in many cases where there are concerns about the safety of out-of-hospital births, it's important to explore whether the healthcare system is appropriately receptive to supporting that smooth transfer of care from out-of-hospital midwives. So I want to talk a little bit about how midwives partner with other maternity care providers. So midwives, the training for midwives prepares them to provide independent clinical oversight for pregnant, birthing, and postpartum folks, which means that they don't actually require, based on their training, they do not require oversight from a physician, but states vary in whether the licensure process allows midwives to practice to that full extent of their training, or whether they need to be supervised by a physician. Additionally, in addition to supporting births, midwives are often found as part of an OBGYN office where they might provide prenatal, postpartum, well woman care. And this is a model that can help to reduce healthcare costs. And then as I previously mentioned, midwives can be found supporting births in the hospitals and out of hospitals, which allows them to reach folks who maybe don't have easy access to typical healthcare structures and systems. And then, as I've mentioned, midwives are experts in normal physiologic birth. So midwives specialize in low-risk births in the way that OBGYNs specialize and have expertise in managing complications that might develop over the course of pregnancy. So midwives are really specialists in this normal physiologic birth and in really helping to keep folks healthy. And then, I think I got ahead of myself here. In cases where a pregnancy becomes higher risk, a midwife, as I mentioned, will refer the patient to an OBGYN and may continue to support that patient in partnership with the OBGYN. And then finally, super important to mention that midwives could be a really important part of solving some of our rural health challenges. They provide cost-effective obstetric care for low-risk women and might be able to provide that care outside of the hospital context in some settings. And that's important since many rural communities are facing closure of their hospitals and increased travel times to access perinatal care. So midwifery care could be a way to sort of bridge some of these gaps. So let's turn our attention to doulas. So there are a lot of different definitions for doulas out there, and doulas often will self-define maybe differently than this. This is one definition of doulas. Doulas provide emotional, informational, physical support to pregnant, birthing, and postpartum people. The thing that's really important to recognize about the difference between a doula and a midwife is that doulas don't provide any medical care. So midwives have medical training to oversee the medical care of a person who's having a baby, and doulas do not provide medical care. Typically, they don't do any sort of medical procedures. So many doulas do complete training of some kind to enhance their ability to provide support to birthing folks. There are hundreds of different options for doula training in the United States, and there's no like one accrediting body for doula training in the way that there are accrediting bodies for midwifery education. And I wanted to just quickly make note of community-based doulas specifically, because a lot of the legislation happening around doulas is really related to Medicaid coverage for doulas. Ultimately, community-based doulas are likely the most effective model of doula care for supporting Medicaid recipients. So I wanted to make sure that I just showed some of the ways that these doulas are unique from like a birth doula. And so as an example, as a birth doula, I typically see a client maybe once or twice during their pregnancy, and then I see them and support them during their birth, their labor and birth, which is what people think of when they think of a doula. And then I might check in with them once postpartum. Community doulas often, or community-based doulas often begin supporting clients earlier in pregnancy, do far more than 1 or 2 prenatal visits, and they'll incorporate different educational topics, and they might help with coordinating care. They also support clients during labor and birth, but then they continue to provide that support regularly for several weeks and sometimes months into the postpartum period. So it's just a much more comprehensive model of support than kind of what like a birth doula or a postpartum doula does. So some roles of doulas in maternity care here. So by providing consistent support, doulas really see clients much more typically than most obstetric providers get to over the course of a patient's prenatal care. Clients tend to trust doulas really deeply, and that really allows doulas to help them move through the labor and birth process with greater confidence and less fear and less stress, which just makes the process safer and smoother for everybody. Doulas are also often will help clients advocate for themselves, and that often looks like helping them gather their questions together. So if there's a specific procedure being recommended, the doula will help the client sort of figure out what their questions are so that they can make an informed choice. Doulas will also often help to connect clients to additional services that they might benefit from. So for example, a perinatal mental health provider or a physical therapist or an acupuncturist or chiropractor, things like that. And then as a doula, I always tell my clients that it's their medical provider's job to watch out for their physical safety and the safety of their baby. And then it's my job to fill in the space that's around that, right? Everybody's number one priority is for a healthy mom and a healthy baby. And as a doula, I sort of fill in the space around that. So I'm thinking about comfort and emotional safety and information and kind of the stuff that is important to folks coming through this experience feeling whole. So doulas work with any sort of obstetric provider. That's another thing that's sort of unique about doulas. They follow the client. So if the client's working with an OBGYN, then the doula is working with an OBGYN. If the client has a midwife, then the doula is working with the midwife. A key characteristic of doulas is that they work with the client for the client independently. So they go where the client goes, and they partner with whatever kind of provider the client has. And this is also interesting because it means that doulas have a really unique view of the maternity care system. They go to every hospital in the area if there's more than one. They probably support out of hospital births with midwives as well. they know many different obstetric providers, and that knowledge is part of what makes them really valuable to clients. That kind of firsthand knowledge about what policies and practices look like in hospital settings, and what clients can expect in terms of how those policies are going to play out for them in their birth experience. And I want to just briefly note some of the ways that midwives and doulas can be really positive tools in addressing the racial inequities that we're seeing in maternal and infant health outcomes across the country. So racially concordant care here refers to both doulas and midwives. So just in the research that we have shows that people have better outcomes when they have the option to see themselves reflected in their care providers. Currently, the numbers of doulas of color are certainly growing, as are midwives of color, but barriers to the midwifery profession especially make it hard for birthing people to find a care provider who reflects their racial identity. And this could be limiting the potentially positive impact of the midwifery model that the midwifery model of care has for maternal health. So actively investing in the growth of Black and Indigenous midwives especially could have a really significant impact on improving racial equity in maternal health. And then similarly, actively investing in policies that reduce barriers to becoming a doula and growth of the community-based doula profession specifically could prove to be another step toward racially equitable maternal health outcomes. So I'm just going to wrap up with a few policy considerations for midwifery and doula legislation. So for midwives, first I want to emphasize that midwives, I said this before, but midwives are trained and prepared to be independent clinical providers. So it's important for lawmakers to consider whether the laws that they're proposing might limit the scope of practice of midwives and therefore might create inadvertent barriers to accessing the midwifery care for patients. So as I said before, for all of us, the #1 priority is safety of the birthing person, the baby. But independent bodies monitor and accredit midwifery schools to ensure that midwives receive appropriate training to serve as independent clinical providers. And in many states, they are independent. So it's important for lawmakers to examine outcomes in those states and consider how laws can support midwives to practice to the full extent of their training. It's also important to consider what barriers might exist accidentally, including through fees or regulatory processes that restrict the ability of midwives to serve patients, and think about what can be done to mitigate some of those. And then finally, it's absolutely essential that any state embarking on midwifery legislation seek out the perspectives, especially of Black and Indigenous midwives practicing in and out of hospitals in their state, and bring them into the process of drafting legislation and regulations. So that on-the-ground expertise can help to identify any significant barriers that might exist before they're signed into law. And having the support of the midwifery community can significantly improve uptake of new licensing requirements. And then finally, I'll wrap up with some considerations for doula legislation. So as I said, there are kind of a few different types of doulas. There are birth doulas, postpartum doulas, and there are community-based doulas, and the roles of each are slightly different. So it's important to consider what kinds of doulas you're trying to reach with your legislation and making sure that that's kind of considered in the legislation as you write it. So as I said previously, likely for legislation that pertains to Medicaid coverage for doulas, research suggests that community-based doulas may be the most impactful type of doulas to serve Medicaid recipients. So considering the scope of a community-based doula when creating that legislation is really important. Oftentimes, doula legislation is drafted with similar parameters to other healthcare licensing legislation, and that can be challenging because doulas are not medical providers. So there's no singular certifying or licensing body for doulas, and many doulas feel strongly that creating that licensure process could create really significant barriers to the profession. That's ultimately about women supporting women. So licensure could create unnecessary regulation and significantly limit access to doula support. And it might not be necessary since doulas don't actually perform any medical tests or procedures. So that's something to keep in folks' minds as they're thinking about doula legislation. And then finally, as I said with midwifery legislation, bringing doulas into the process of developing that legislation early is so important to ensuring that you have a law that doesn't accidentally create barriers and increases community buy-in. I get excited when I've seen some doula bills that have like an advisory board of doulas as part of the law. I think that's a great way to keep folks engaged. So I know I covered a lot and quickly, but I'm excited to hear from our legislators. So I'm happy to answer questions at the end, and thanks so much.
Thank you, Ms. Degger. Really appreciate your presentation. And so, yeah, if you have questions for her, please enter them in the Q&A box now, and we can get to them at the end of our presentations. Now, next up, we have Kine Wen, a project manager in NCSL's health program. Kine will provide examples of recent state action to address midwifery and doula care. Kine, the floor is now yours.
Thanks, Emily. Hello, everyone. Today, I will be sharing some trends we've seen in state legislation related to midwives and doulas over the last 2 years. Many states have passed bills to address maternal and infant mortality and morbidity using options such as mortality review committees, healthcare quality improvement, provider training, insurance coverage, among others. And as Jessica shared, states can also look at access to midwives or doulas as tools to address unique needs in their states. So first, we'll look at trends in midwifery legislation. Several states have passed bills related to training, licensure, or reimbursement for services. For example, California just this month passed the Midwifery Workforce Training Act with activities aimed at increasing the number of trained certified nurse midwives and licensed midwives. The District of Columbia recently licensed and regulated midwives and added Medicaid reimbursement for certified professional midwives. Louisiana passed legislation requiring health insurance coverage for services provided by all state licensed midwives, which include certified nurse midwives and certified professional midwives. Oklahoma recently provided licensure for direct entry midwives and created the Advisory Committee on Midwifery. And for reference, certified nurse midwives are licensed to practice in all 50 states, and approximately 37 states now license, certify, or otherwise regulate certified professional midwives. Other states have addressed practice authority for midwives. Arkansas, for example, recently provided certified nurse midwives full practice authority, removing the requirement for a collaborative practice agreement under a physician when practicing in defined and approved authorities, prescription schedules, and deliveries in accredited facilities. They join about 28 other states where certified nurse midwives practice in an independent practice environment. California changed several provisions related to certified nurse midwife scope of practice, allowing for expanded practice and prescribing authority as mutually agreed upon with physicians with a signed agreement. Minnesota modified the scope of practice for licensed traditional midwives to include ordering standard prenatal lab tests and imaging. And Nevada clarified that midwives include certified nurse midwives and certified professional midwives, and that they can practice in freestanding birth centers. Next, we'll look at doula legislation, which is more of an emerging policy trend. For example, we've seen at least 17 states and DC consider 25 bills on doula care and coverage during the 2021 session, compared to 13 states and 16 bills 2 years ago. In terms of enacted legislation, states have passed resolutions and addressed doula certification and access in certain settings. For example, at least 4 states have recently passed resolutions. New York memorialized the governor to proclaim a state doula week. Tennessee recognized doulas as vital birth team members and community health workers and acknowledged their contribution in ending maternal and infant health disparities. In terms of certification, Arizona established a voluntary certification for state certified doulas, but does not require this to practice as a doula in the state. They also established a doula community advisory committee. Connecticut directed the Department of Health to conduct a scope of practice review to determine whether the state should establish a certification process for doulas. Most states do not require specific certification for doulas to practice, but some may require doulas to become certified by certain approved training programs to use certain titles or receive certain reimbursement. At least 4 states specifically address access to doulas in different facilities. Colorado, for example, required certain health facilities to allow every birthing person to have a companion or doula in addition to a partner or spouse. And Oklahoma required correction facilities to provide pregnant inmates access to a support person that may include a certified doula, provided the services are not charged to the facility. Other states have addressed coverage for doula services. These examples show a range of approaches that states have taken related to reimbursement for services. This includes legislative approval for Medicaid coverage, such as in Indiana and Nevada. Louisiana created a doula registry board to promulgate rules for registration and health insurance reimbursement. Rhode Island required health insurance plans to cover perinatal doula services. And finally, Virginia convened a work group to evaluate the costs and benefits of providing Medicaid coverage and to recommend reimbursement rates. At least 7 states and the District of Columbia have approved Medicaid doula coverage, though not all have been funded or implemented at this time. Several other states have also implemented pilot programs or special programs through non-legislative actions. I hope these legislative examples were helpful in providing a snapshot of recent policy trends. You can browse our maternal and child health legislative database for enacted bills on this topic. Check out other resources in our resources document that I'll be putting into the chat box shortly. And of course, reach out to me with any specific questions or requests. Thank you.
Thanks so much, Kai. All right, so next up, we have Delegate Lasheries-Aird, who serves Virginia's 63rd House District. Delegate Aird will share her legislative work relating to midwives and doulas. And just again, as a reminder, Delegate Aird has to head to another scheduled event right after this. So we will be taking questions for her immediately following her remarks. So please, again, send your questions into the Q&A as soon as they spark. So with that, Delegate Aird, thank you so much for joining, and I will turn it over to you.
Great. Thank you so much, Emily, for that introduction, and good afternoon to everyone. As shared, I am Lasheries-Aird, and I represent the 63rd District in the Virginia House of Delegates. And I've been serving there since about 2016. I really appreciate today's conversation on the focus relative to midwives and doulas, because I can remember when I first started on this journey, and I will tell you that began probably late 2018, and it has taken up until 2021 to really get to a place where we have actual policy in place that is already beginning to combat infant and maternal mortality. So today what I thought I might do is go through a bit of timeline relative to the legislation that we needed to put in place to get to where we are today, which is what I consider to be some really impactful legislation and financial investments, but then also talk about some of the lessons learned for anyone else who's considering going down this path in their state. And so ultimately in the Commonwealth, working alongside the governor and many of our agencies and partners, we've set an aggressive goal of trying to eliminate racial disparities in Virginia's maternal and infant health outcomes by 2025. And so myself, I have worked directly to try and address primarily the most pressing needs, and then try to attack some of those systemic problems over time. So I've carried specific budget amendments for funding, legislation for doulas, and currently am actively on a work group regarding the implementation of some of the policies that we have moved forward. Our strategies have included a variety of actions and collaborative approaches with providers. And if you're going to start down this path, I would say that at the onset, you need to make sure you have a strong data collection and research arm, because that's really going to inform the policy and the financial investments that you need to make. And so that is where we started in Virginia. And then you have heard throughout many of the presentations that you really need to engage your partners on the ground. And so we have been working alongside as legislators and as the executive branch. We've been working alongside both certified professional midwives, doulas, obstetricians and gynecologists, reproductive health advocates, child advocates, and any other stakeholders on the ground in your state that is doing this work. You want to, again, I just can't reiterate enough, bring them along for all of these conversations. In April of this year, it was very exciting that we released a maternal health strategic plan that highlights both common barriers among our communities. Again, this was put together after we did listening tours around the state, engaged our research partners and looked at our data really closely, and put together 6 specific strategies that will guide us from now through to 2025. And so from a very high level, those strategies include improving health insurance for women of reproductive age, improving the healthcare environment for women of reproductive age and pregnant postpartum women. And all of these break down with very specific tactics underneath to attain the strategies as well. I should note that. Improving the criminal justice and child welfare responses for pregnant and postpartum women seeking care, to improve the availability and access of wraparound services that support pregnant and postpartum women and their families. And you'll hear me say postpartum a lot because one of the things we learned a lot along the way is that, you know, from the onset, having that support and that care from the moment someone determines that they are expecting, the postpartum period is equally important as well. And so you'll hear me talk a lot about that. But then also increase access to comprehensive reproductive counseling and contraceptive options. And lastly, improving data collection oversight in order to drive action and enhance accountability to improve maternal health outcomes. So those were our 6 primary strategies that came out of our strategic plan. But I'd like to also give just a quick look back again at where we started. So before we had any of the legislation we had to date, the one thing we did have in existence was a infant and maternal task force that really was responsible for trying to assess any loss of life that was occurring. But what we found when we looked at this review team, the reports were being issued, data was being provided, but they ultimately were not being used in a way that directed action and or was being provided to providers so that they might change practices along the way. And so one of the first things that we did was take the fetal and infant mortality review team and codify them, adding both additional reporting requirements that needed to be provided to the stakeholders, policymakers, but also the executive branch. So we did that in 2019. And then we also added perinatal anxiety to the list of info that providers must provide to patients as something to look out for, something to be conscious of, to try and eliminate another one of those causes that might lead to infant or maternal mortality. In 2019, we also invested $22 million ultimately to increase Medicaid coverage for new moms, increase home visiting, and explore a Medicaid reimbursement for doula support services. And again, that number was very specific to what Virginia saw its needs as, and ultimately we're tracking very closely to what some of the national data shows relative to the disparity among Black and Brown women relative to infant and maternal mortality. And so that was our starting investment to try and combat this crisis. In the 2020 legislative session, we went even further. So part of that $22 million was to assess whether or not a reimbursement for doula support services would actually have a significant impact. And we found that it would. And so we, in 2020, the governor put forward a reimbursement of about $859 for Medicaid reimbursement. And that would include about 8 prenatal and postpartum visits for attendance and delivery. And also some additional support, again, trying to combat some of the postpartum challenges that we are seeing along the way. In 2020, we also, I introduced legislation to create a state certification for community doulas. And you heard some of this in the last presentation, that can be very tricky, trying to establish a certification specifically for your state, because where the training to date and previous credentials are obtained, there are a variety of them. And so this was where it was really critical for us to engage with our doulas that were on the ground doing the work to make sure that we were not creating another layer of assessment for training they had already received, or that we were eliminating recognition of their certifier to date. And the one thing that I would also emphasize for this is we had to have the state certification in order to have the Medicaid reimbursement to have our doulas eligible for the Medicaid reimbursement. And then also as part of that legislation was the establishment of a state registry, which is all about trying to increase access for those who were seeking those services. In addition to that, again, on the data collection piece, we developed a maternal health data and quality measures task force to make sure that although we're beginning to walk down this path of combating this crisis, we're continuing to assess the progress that we're making along the way and any other challenges that come to light. And we also added the establishment of a maternal health awareness month in July. Relative to budget actions in 2020, our Secretary of Health and Human Resources convened a work group to review the recommendations regarding the regulation of state doulas and that community doula benefit that we talked about a little earlier. And this work group actually is currently still meeting. I'm part of it. And the reason this work group is so critical is because we found that although we were now allowing for this reimbursement, many of our community doulas had no idea how to bill with the state, how to actually go about implementing this benefit that they were now able to receive in support of the individuals they were supporting. And so we are still meeting to date to try and make sure we get that right, but we could not have done that without continuing to engage with them on the ground. During this past session, and you heard a little bit about this earlier, we put in place Virginia's own definition of practice of licensed certified midwifery, and we also elevated the licensure of certified nurse midwives. And so again, there are many different definitions probably across the country, but we specifically identified what we would define this as in the Commonwealth. And furthermore, we also passed legislation to allow for greater independence of practice for our certified nurse midwives to combat the challenge we were seeing in our rural communities, as well as just eliminating, especially during the pandemic, that additional authorization of a physician being present for our certified nurse midwives. Looking ahead to 2022, even having done all this, even with a strategic plan now in place to direct some of the work that we will do moving forward, some of the feedback that we have received is that we might want to look at restructuring our payment models for maternal care. The benefit is still fairly new, but continuing to tweak it along the way is going to be one of the things we're going to look at, as well as increasing funding for midwifery programs across the state. Furthermore, just trying to continue to combat the systemic problems that we also know are an issue, providing perinatal providers with complete implicit bias training to serve patients more equitably. And this is mirroring some of what we saw happen in California under their Dignity in Pregnancy and Childbirthing Act. And lastly, creation of a sustainable community-based maternal health hubs, which also provides both supports to the doula and midwifery communities, but then also just the provider community in general, as we try and specifically target particularly Black and Brown mothers that have just a higher rate of disparity here in the Commonwealth. And so those are some of the things that we have done in Virginia, which I'm extremely proud of, but we absolutely have a long way to go. And I'm happy to answer any questions from other policymakers and or stakeholders on the call about the work that we've done here in Virginia.
Well, thank you so much for sharing the work in Virginia. I really appreciate that. So while we wait to see if more questions come in the Q&A, I would just ask, what was your biggest takeaway in working on this legislation?
Yes, my biggest takeaway was the moment I introduced my first bill and I received so many emails about the proposal that I had put forward from both the midwifery and the doula community. And I just cannot emphasize enough how critical it is to work with your stakeholders on the ground. During all of our listening sessions, providers were just so helpful in making sure we got our legislation right, because it really could do what was mentioned earlier, which is either put additional barriers in place or have unintended consequences, both for those trying to utilize the services as well as those providing those. And so you cannot do anything without engaging your stakeholders. But then furthermore, the data collection and the research is so critical as well, because every state is going to be a little different. Although this has become a nationwide conversation, knowing specifically the data for your state, knowing specifically the data for your types of communities, and then pairing that with your stakeholders is the only way you're going to get impactful legislation in this on this topic.
Great, thank you so much for that insight. And then just a quick clarifying question, as part of that work, did you work directly with your state's health department?
Yes, there was a huge task force, actually several that broke down along many different lines that were included in our initial work. But then largely when it came beyond the assessment, beyond the research, when it came to the actual policy, we worked more with our Secretariat of Health and Human Services, DMAS, which is sort of the Department of Medicare Assistance here in Virginia. We work more closely with them, and then a select group of providers to really hash out the specific details of how such a benefit and how some of this legislation would work in Virginia.
Well, great. Well, thanks again so much for your remarks today, and thanks for joining us. We appreciate you. All right, so now we're going to hear from Representative Stephanie Hilferty, who serves Louisiana District 94. She's also going to share her legislative work and lessons learned related to midwives and doulas. The floor is now yours, Representative Hilferty. You're on mute, though.
On mute. Sorry.
There we go.
Thank you so much for having me. I participated in the NCSL program, maybe like 2018, 2019, something around there. I found it really valuable and enjoyed participating in the program. I want to highlight some of the recent legislation, and we actually did have a bill on midwifery and doula services this past year that was run by my friend, Representative Matt Willard. And so he was successful in that bill in requiring all Louisiana insurance policies that provide for maternity benefits that they cover midwifery services, implemented co-insurance parity with physicians. Insurers must reimburse midwives at in-network rates. And this applies to certified midwives and certified professional midwives. He also created, and I think this is interesting, laying the ground for the doula side, he created a statewide doula registry board to begin the process of having doulas reimbursed by insurance companies. The board is composed of doulas who will start drafting the reimbursement process, set the guidelines to pursue grant funding, and review and approve applications for insurance reimbursement. I'd like to address, I think in the chat box and the question and answer, somebody did ask the question about creating that piece between a midwife and then if there's the need to transfer that patient to the hospital. And while this isn't specific to that point, back in 2019, I worked with the Louisiana Department of Health as well as with our freestanding birthing centers to create a process that every freestanding birth center would have an agreement with a nearby hospital and have that procedure already set out. This is something we worked, and I think Delegate Arid pointed this out, that having partnerships and having worked with those partners ahead of time prior to introducing the legislation is so key. This was a bill that the Department of Health had worked with those freestanding birthing centers on. And so because that groundwork was laid and the heavy lifting was done on the front end, this was a bill that went through the process pretty seamlessly. So that was some legislation we passed. So not quite the question, but I think it's in that same realm as far as how you get those patients to a hospital if it is necessary. And something else I want to mention that I worked very closely with Representative Mandy Landry on this past legislative session was extending postpartum coverage for our mothers, our Medicaid patients. We do plan on bringing this piece back. It had bipartisan support coming out of the House, and unfortunately on the Senate side, we were unable to find the funding. But I anticipate it will come back again. I think this was something, and I think speaking to the bipartisan side of it, and I think Delegate Arid mentioned this as well, is that looking at that postpartum side, yes, obviously we're getting the mothers through this pregnancy and we are looking at their health throughout that, but there's so much that occurs after that baby is born, and that is really can be a challenging time for the mother and for the family as they adjust to this new baby. And so looking at that piece, we had support, I think it may have been unanimous support on extending that postpartum coverage. So I thought that was really, obviously we didn't pass it, which is unfortunate, but I think it speaks highly of our efforts going into 2022.
Yes, well, thank you so much for sharing those remarks. So along those lines, when you mentioned not being able to pass some of these things, what would you say were maybe some of the biggest challenges in approaching this topic in legislation?
I think there's a level of, I think certainly there is a level of education that needs to go into, especially when we're talking about midwifery and doula services. I don't think we should assume that our colleagues necessarily know what that means. And I don't say that in a pejorative manner at all. I think there needs to be that level of education. I mean, certainly some of my colleagues are, maybe grandfathers, and, the birthing process was years ago to them, or maybe their grandmothers. And so laying out the groundwork of this is what this service does, this is how it's used, and these are the outcomes, these are the favorable outcomes that we see in this. So this is why we are looking for this outcome. So I think the education piece is key as we work with our colleagues.
Well, great. Thank you so much for your remarks. Really appreciate the insights of what's going on in your state. So I'm going to move to some more general Q&A. Let's see. So I think this one's for Ms. Steiger. Wanted to ask, how can state maternal and child health directors be a resource to policymakers interested in learning more about these policies and best practices, particularly unique to their states?
Yeah, absolutely. I think this is a great question. So MCH's members are really Title V and state maternal and child health directors and staff. And I think that legislators can and should look to them as subject matter experts in maternal and child health. So talking to them about some of those data collection pieces that Delegate Aird mentioned, talking to them about connecting to organizations that maybe the state health department has partnered with that might be good stakeholders to partner with in the development of legislation. I think in general, state MCH maternal and child health directors can give a great sort of high level overview of what maternal and child health looks like in the state, and give information about everything from like hospital certifications that might be relevant to information about sort of the existing state of maternal health. So I think that's a great place to start for kind of information gathering, and they can be really great partners for connecting to other resources and people as well. You are still muted, Emily.
Thank you for that. So I think I'm going to keep going with you here, Ms. Steiger, to ask, can you share a bit more about how midwives and doulas can help address health inequities?
Sorry, it cut out right at the end there. How do midwives and doulas?
Addressing health inequities, just a little more on how they can really help address that issue.
Sure. I think so the issue of health inequities is really complex to some extent. And I think that when I think about how midwives and doulas have the potential to sort of address inequities, a lot of what I'm thinking about is sort of the kind of care that they offer. So there's some research that suggests that providing sort of just tender, supportive care actually improves birth outcomes. And that's not to say that obstetricians and gynecologists don't provide tender support and care. Many of them do. I think that the midwifery model of care is really designed to give more time than what often is available in a physician's setting. It's just the billing is different, the model is different, and the midwifery model of care is really about more time with patients and focusing on kind of preventative measures. So I think a lot of what midwives are doing is educating patients on what they have control over, and also connecting them to support for the things that they don't have control over. And the reality of racial inequity, or of inequities in general, racial, income, whatever, educational, the reality is that so much of that is very much out of the control of an individual person. So when we think about like what can midwives and doulas do to improve inequities? It's really about the systems level. So by having a midwifery model of care that's accessible, that is working at full capacity, where midwives are serving low-risk patients and able to get support simply, easily, without judgment from hospitals and physicians when they need it. That's really about creating a system where the like underlying expectation is that folks kind of get that additional support right from the get-go. Doulas are similarly really about providing informational, emotional support that sort of fills in all of the spaces around the medical safety aspect. And I think it's really about having broad access so that we have a system in place that improves folks' ability to gain supportive, positive care. So I think it's, in my opinion, less about like what can one individual doula and one midwife do, though I'm sure that there's a lot. I think doulas, especially in the postpartum period, help clients advocate for themselves. So if there's unusual bleeding, for example, a doula is gonna know that's too much bleeding. You need to reach out to your medical provider, and if a patient isn't being listened to, can help them find somebody different or find other routes to accessing the medical system. So they're kind of there to support some of that. So I think a lot of it is about having a system of access in place. And that when we have access to midwifery care and doulas broadly for folks who are falling into populations that experience inequities, we have a better shot of those folks having better outcomes.
Thank you so much for that answer. We also got a question here. It says, we've heard that pregnant women with COVID are at higher risk of complications. There's also issues with health inequity in COVID as well. So how has COVID affected the use of midwives and doulas? Is that anything you can speak to, Ms. Steiger? And if you'd like to add, Representative Hilferty, anything you've heard going on in your state, that would be great too.
Yeah, definitely. I think I can certainly say on the doula side of things that when right when kind of COVID kicked off, there was a very understandable need to limit the number of physical bodies in birthing facilities. Makes complete sense. But the result was definitely that a lot of folks had they couldn't access doula support because they couldn't bring that extra person in unless the doula was their only support person. I think it depends for sure on the state and the context now, but there have definitely been places where we've seen doulas allowed back into hospitals, and places where that's not the case, and that certainly creates challenges. Doulas are pretty resourceful as a bunch though, so they find ways to provide virtual support. It's not the same, but it's certainly better than nothing. And I think for midwifery care, I suspect it very much varies by the modality of midwifery care. So in a hospital-based setting, I think that I will say that there are definitely additional pressures on the healthcare system, and especially when you have folks who can't bring the support that they were planning to bring into their birth, it puts additional pressure on the care providers in the healthcare setting. So even if you weren't planning on bringing a doula, let's say you're planning on bringing your mom in, and you can't bring your mom, and now your support system has sort of like been shaken. This puts a lot of extra pressure on your medical providers to now fill in roles that, like, they're supposed to be focused on your medical safety, and now they're also trying to think about your like emotional well-being. And thank goodness for incredible healthcare workers that care so deeply. But it just has, I think COVID has put a lot of strain on the medical system at large. And while, yes, you can still go into the hospital and have care from your midwife if they're hospital-based, and most home birth midwives were still serving patients. I think right at the beginning of the pandemic, we saw a lot of states where we would see sort of patients getting very nervous about having babies in hospitals due to the potential for a COVID exposure. And so folks would switch very last minute to out of hospital birth settings. I know I'm in the DC metro area, and there was like a 3-month period where all of a sudden none of the home birth midwives had any availability, and they've been incredibly busy since then. So it'll be interesting to see, when we have data, how this sort of shakes out.
Thanks for that response. All right, well, I think we have run out of our time today, but want to extend a final thank you to our presenters. We really greatly appreciate your time and the expertise that each of you were able to share with us today. Also appreciate our audience for participating today and submitting your questions, and appreciate those of you who shared some additional resources in the chat. And as a reminder, a recording of today's webinar and the presentation slides will be available on NCSL's website within a week or so. So thank you all again so much.
Thanks.